Hi all, there's a few issues that we wanted to push out to you guys. First of all, I was asked to do some education on the different blood release options that you have. If you do an emergency release of blood products, it will release 4 units of packed cells. If you've already typed and screened or typed and crossed them, it'll release those. If not, it'll give you unmatched blood. And if you call for a massive transfusion protocol, that actually releases 8 units of PRBCs along with the FFP, and it starts to mobilize platelets. What we are being asked is to actually start with the emergency release. And if we need additional products, like if you're a couple units in and you're thinking, okay, this is not staunching the flow, or we're going to need more products, go ahead and call the massive transfusion overhead. It'll mobilize more staff and all that for you, as well as the products. But what's happening is we're actually overutilizing probably the massive transfusion protocol, whereas it's not always appropriate. Their patients are getting a couple units of red cells and then they seem to kind of perk up and we're not needing the whole shebang. And what's happening is we're ending up throwing away a lot of blood products. So the Red Cross had a meeting with a few of our people that do the blood stuff, and they said that we're actually overutilizing. So what I would recommend is that we start again with the emergency release, which will bring up 4 units, and then a couple units in, if it's looking like go ahead with the MTP, that's totally fine. But until then, we do want to preserve products and be responsible as much as possible. Another thing that came up with an admitted patient was that if a nurse alerts you of abnormal skin findings, can you make sure it's somehow documented in your chart, even to the point where you could say, some early decubitus wounds are present, please see nursing notes and photo documentation, or just refer to it in some way. It doesn't have to be super detailed, just noting that there are abnormal skin findings. Don't forget to put in the consult order. We are really having trouble holding some of our consultants accountable, and some of them are pulling the ER didn't call me. So if you guys will put in the consult order, it's protective of us, it's protective of the hospitalist, the patient, and it's accountability for our consultants. Also, I got an email from Dr. Maines with urology, and he said that there's kind of a breakdown in us making sure that we're sending over clinic consults through that message system, so that selecting that HBOC, Sonora Urology, we can do that for urology, cardiology, and GI right now. But there's a little bit of a breakdown on our end, and so the patients aren't getting appropriately scheduled. So if you'll please remember, even if you talk to the urologist, to go ahead and send that consult through, it alerts their clinic schedulers to get them in a timely manner. You may have already noticed, but there's no IV push diltiazem because of a national shortage. So you can get the drip, but not the IV push doses. From the ED, they can't do those quick skilled nursing facility placements anymore like they could during COVID. So now, again, the patient has to have a qualifying inpatient 3-night stay to be able to be placed in a SNF. So that means that we may end up having more admissions if they'll qualify. So it'll be a lot of conversation between the case management, probably hospitalists, and us. Don't forget to utilize teleneurology. The hospitalists do ask that if we can go ahead and let the neurologist know about the subacute CVAs that we're not pushing TPA on, but that likely will stay in the hospital. If we'll go ahead and get the consult rolling for that, it would be helpful for them in their admission planning. And they're hopeful that we won't have to admit some of them, but I don't think that's really going to be the case. But I think that's why they're pushing for us to do it. if you guys can make sure that you're completing at least your labs before you're calling the hospitalist for admission, making sure there's a creatinine, and as much of your workup is completed as possible before admitting. There's been a couple of instances, and actually I did one not too long ago where I admitted and then there was something that came up that actually changed the course of them getting admitted here. So we had to undo the admission. That was my bad, but I'll pass along my mistakes to you guys so that you won't do them as well. If you will let me know if you're getting strange pushback on cases for admission, please just email me, because I'm trying to work through all of these with the hospitalist director. I'm getting some really strange things, and I'm trying to get to the bottom of why this is becoming an issue. So if you'll keep track, and again, shoot me an email of a weird pushback, so that way I can really hammer them out with them. We can kind of see how often it's happening and get a good handle on it, so we're not having to constantly fight admissions, especially when they push back for strange reasons like we need inpatient rheumatology. I did speak with the associate chief nursing officer at Stanford because we were having trouble sending Stanford patients back to them. They recently had a policy go into effect that if they have a patient that has complications from a procedure and it's been within 30, if it's within 30 days of that procedure being done and they present to our ED with some sort of complicating event, they actually are supposed to be high priority patients for them to accept. So make sure that when you're calling Stanford, that the transfer center is aware that this is a recently post-op, within 30 days or post-procedure patient that needs X, Y, and Z, so that they could actually ratchet it up their list. Now, if you still get pushback and they say, I'm sorry, we're absolutely full, please ask to talk to the service that did that procedure, because that also can help. If you continue to get pushback and you really think it's important, I do have the phone numbers for the transfer center director and for his boss now, so we can then prioritize it hopefully even more. So if you're having trouble like that biliary stent or the various things, the urology patient that we had, please let them know, again, first of all, that it is a recent procedure. Second of all, that if they say no, get that surgeon on the phone. The Manteca ambulance unionized, and we are concerned that there are going to be more delays than we have even been previously experiencing. The other night we had an NSTEMI dialysis patient that they decided they didn't need to transfer urgently and they instead wanted to sleep. So the patient ended up signing out and driving herself down the hill, but it's pretty unfortunate. So we are trying to attack this from multiple avenues. We have administration working hopefully with the county supervisors. We also have reached out to the EMS director, but I need you guys to document in the chart when this is happening. The nurses will alert their directors of delays like that, and we're going to just start hammering on it, because that feels to me, being the doctor at the bedside, unacceptable that someone else would tell me no on a transfer. Thank you for avoiding femoral central lines. That is saving the patient having to get their lines replaced, so I appreciate you avoiding that. Our sepsis numbers are looking really good, so that's another thing that I'm really grateful for. And then the last thing that we were talking about today, and maybe you guys can help me with this, is we were talking about kind of scripting when we get into that cycle alongside the hospitalists, and they're asking us to call their consultants for them, but with questions that we don't have necessarily. So when we've called and said, hey, cardiology, can we accommodate this patient here? And then the hospitalist has 37 other questions about, their anticoagulation and their meds and all that. those are really management questions that I find they probably need to work out together. So my thought was, if we can script it and all say the same thing to the hospitalist, they might get the clue. So what do you guys think about saying, I've had my clinical questions answered, and then in order to keep the patient safe and to reduce the chance of errors, I request that you call the specialist directly. So I'm going to see if we can try that in the next couple months. If you guys will jump on board and at least use some of those keywords, I'll stick them up for you. But I really want to know if it'll move the dial a little bit in this weird phone allergy that they have. So anyhow, let me know. Those are the updates for now. Thanks so much for listening in. Bye.